Now, today's are another lecture on a series of lectures making a diagnosis on clinical evaluation of the patient. Now, today we're going to discuss a symptom, that is a patient who presents with fit or an epileptic seizure. Now, when a patient comes with fit, they generally land in the medical emergency. And what you have to do is you have to take certain urgent steps before you make a detailed diagnosis or evaluation attempt. So first make sure that patient's airway is clear, breathing is ensured, patient is placed in a place where patient is not prone to develop injuries. So you prevent aspiration. If there is aspiration, it may cause choking and respiratory embarrassment, and it may also lead subsequently to aspiration pneumonia. And the third, the most important thing is you go for checking the blood sugar. Hypoglycemia should be immediately assessed. If it is there, it should be corrected, because this is a potentially reversible thing and it should be done on urgent basis, because if the hypoglycemia prolongs, it causes some sort of permanent neuronal damage, particularly the neurons of the cerebral cortex, which are sensitive to hypoglycemia. So these things should be immediately done. And next you assess whether this epilepsy is primary epilepsy or secondary epilepsy. The important differentiating feature between primary epilepsy and secondary epilepsy is the loss of consciousness. If the patient develops loss of consciousness first, this is primary epilepsy. That is, there is no neurological phenomena, patient becomes unconscious and then subsequently has other neurological sequelae or manifestations. So this would be a primary epilepsy. But the patient who has got some neurological phenomena which occurs before the patient becomes unconscious, this is called secondary epilepsy. And this first phenomena is called aura. Aura is important because aura has a localizing value. It tells you where is the epileptic focus, where this cerebral dysrhythmia actually arose from. And this can be very varied depending upon where is the lesion. Patient may have very varied manifestation. There may be motor manifestation, there may be sensory manifestation, there may be autonomic manifestation, there may be manifestation from special senses. So a patient may have very varied manifestations with the aura. So you try to locate what is the possible aura. Sometimes the patient's attendants or the witness who have seen the episode, they can tell you, but once the patient becomes conscious, you can also ask the patient what was the beginning of this epileptic fit. The patient may sometimes tell you that patient had a particular type of experience. For example, patient had a taste in the mouth, or patient had flashing of light, or patient heard some voices and then he became unconscious. So this will tell you where is the focus of this cerebral dysrhythmia located. And then now we see how can we see what happens actually. You see, dense reticular activating system is present in the brainstem, and in the cerebral hemispheres it's slightly more scattered and dilute. When there is an epileptic focus which is in the dense part, that is in the brainstem, the patient becomes unconscious. This is primary epilepsy. And if this current does not travel anywhere, patient remains unconscious for some time and then becomes conscious again. So this is classical absence attack, or the petit mal. Patient has a stare and comes blank, and then patient comes back immediately. So this is one way the epilepsy can go. And if this current, for example, travels downward into the spinal cord, patient may have loss of muscle tone and power and patient falls. This is called drop attack or an akinetic fit. And similarly, if this current travels upwards, this produces the classical grand mal phenomena. Patient has the classical fit. This is called grand mal fit. So this may happen like this. The patient becomes unconscious and then patient has those motor manifestations which are seen generally and described by people as epilepsy. Then if the focus is present somewhere else, for example, in some peripheral part of the central nervous system, it may have manifestations because of the area it is affecting. the function of that area will be reflected as the aura. That is, for example, if this focus is in the temporal lobe, patient may have auditory features, or patient may have gustatory features, or patient may even have some type of visual hallucinations before the fit develops. Now, the difference between the different aura arising from different areas of the brain from temporal lobe is, in temporal lobe, patient has formed type of hallucinations. Now, I'm using the word hallucination. Hallucination is actually perception without stimulation, which is classically seen in patients who've got schizophrenia or similar disorders. The difference between the hallucinations in schizophrenia and temporal lobe lesions is that in temporal lobe lesions, they are intermittent and then short-lived, while in schizophrenia, they're persistent and long duration symptoms. Now, you have to see the aura. Aura, as I already told you, has a localizing value. So you try to find out, and you can find out by your own observation or information from the attendants or the witness, or interviewing the patient after the patient has become conscious. And you see, if this current from the peripheral area does not move, patient only has aura. And you see, sometimes this is a bit tricky because the symptoms may be strange. The patient has episodic palpitations if it is in the autonomic area, and you may be investigating the heart and you find that this is normal, and sometimes patients even are labeled as functional and they're not treated properly. So before just discarding it off, you should give it a thought and evaluate in this context that these strange symptoms, are they because of epilepsy? And now, if this current moves towards brainstem, patient has an aura, and then patient becomes unconscious. So this is another way patient becomes unconscious, but you see there is an aura and then patient becomes unconscious, case of secondary epilepsy. And then if this current moves to other parts of the nervous system, it has manifestation according to the way the current is moving. As I mentioned, if it comes to the brainstem, patient becomes unconscious. And if it goes to the other portion, for example, it goes to the motor cortex, patient may have motor manifestations. And if this spreads to the other side through the corpus callosum, patient may have motor features on the other side as well. So this is classically described in the Jacksonian march, that the fit starts in the arm and then it starts progressing, and it may then involve the other sides, and in between the patient becomes unconscious as well. But when the fit starts in the limb, patient is usually conscious. And you see, if this does not travel, the fit may be localized only to the arm only. So it depends upon how the current is going to move. If it remains there, the patient is going to have symptoms in that area. If it is going to move to the other parts, patient may have different other manifestations of the central nervous system. Now, when a patient comes to you, you have to decide to differentiate between this patient had a fit or a faint. A faint is a syncope. A third differential is patient may have a transient ischemic attack or a TIA, in which the patient becomes unconscious and then becomes conscious. Now, how to differentiate clinically between a fit and a faint attack? Now, first thing is, what we see is the facial color. In patients who've got syncope or faint attack, the color becomes pale because the cardiac output drops, the blood doesn't reach upper portion of the body, face becomes pale, patient falls, and when the patient becomes horizontal, the color is generally restored until and unless patient has some serious problem like ventricular fibrillation. Then in faint, the patient has pale color. What happens in fit? If there is a fit and there is spasm of the respiratory muscles, patient may have cyanosis. The color may become bluish. And if the patient does not have the spasm of the respiratory muscle, the patient facial color remains normal. But you see, most of the patients who become unconscious and have grand mal type of fit, they develop respiratory muscle spasm, and the patients may be apneic and there may be development of cyanosis. And then what happens immediately before the fit happens? The patient cannot tell He can only tell you afterwards what happened. So the patient may have cardiovascular phenomena before the faint starts. For example, patient may have chest pain of myocardial infarction, or there may be pain of pulmonary embolism, and the patient may have palpitations because of the arrhythmia. So these may be present. And then in patients who've got a fit, they may have some neurological phenomena rather than having a cardiovascular phenomena. And then what happens when patient becomes conscious? The color is, as I mentioned, restored, and the patient is, as soon as it is horizontal, the color becomes normal. While in fit, it may not become normal for some time, but when the fit ceases, the color becomes normal. And when the patient becomes conscious, in patients who've got faint attack, the mind becomes immediately clear, while in fit, it remains fuzzy and cloudy for some time before becoming very clear. So the post-ictal examination is very important. If the patient is drowsy and not clear in mind, is confused, the patient might have had a fit. The patients who've got a faint, they become immediately clear about their surroundings and they can talk to you in a very normal way. Patients who got fit, they may remain cloudy for some time before they are mentally clear. And one thing what one has to keep in mind, that the patient may develop a fit because of a faint. So that you have to differentiate, that a patient had a faint and then because of the hypoxia developed a fit. So this is some tricky situation when you need to take history very carefully. So this is how we evaluate a patient who comes with an epileptic discharge or a fit or a seizure. And next time we will take up another symptom.